Good afternoon and welcome to today's COVID-19 update. I'm Heather Fairbairn and I'll be your moderator today. Before we begin, allow me to introduce Dr. Robert Strang, Chief Medical Officer of Health for Nova Scotia, and Dr. Shelley Deeks, Deputy Chief Medical Officer of Health for Nova Scotia. They will each provide a few brief remarks, and then we'll take questions from media participating by Zoom. I'll just remind media to keep their cameras off. Take it away, Dr. Strang.
Thank you, Heather, and good afternoon to Nova Scotians and members. There certainly has been a lot of talk in the last few days about what we aren't doing, should be doing, perhaps in response to the current COVID situation. I believe I've always been honest with Nova Scotians, and I will continue to do so. There's no doubt the current situation is concerning, and as you're going to hear from Dr. Deeks, positive tests are up significantly. Cases in long-term care are up, and hospitalizations are up to some extent. COVID is challenging us once again, and the public health team and I remain very much engaged in the pandemic response. That engagement may not be as visible as it has been in the past, but the work of public health prior to COVID rarely has been. Today, we'll update you on some of that work, less visible. But first, earlier this afternoon, a press release with updates on several important items was sent out. And those items included a second booster dose of vaccine for those 70 years of age and older, as recommended by the National Advisory Committee on Immunizations, will be implemented very soon in Nova Scotia, and more details will be released next week. The availability of Novavax's COVID-19 vaccine will become people will be able to start booking for that if that's their choice, starting tomorrow. And we're increasing the availability of free rapid test kits at more locations, including MLA offices across the province. But before I take you through some details of our transition phase response plan, I want to take the opportunity to address the recent concerns about data reporting on COVID. Last week, we shared our weekly epidemiologic summary publicly for the first time. It's the same report my team and I use for surveillance and monitoring, and we've made it available and will continue to do so for everyone on our COVID website. I believe Nova Scotians should have access to the same data as public health. As I said, we'll continue to make that available on a weekly basis every Thursday. Going from daily reporting to weekly reporting is a big and necessary shift, especially after 2 years. So to start off, I've asked Shelley Deeks, who's Deputy Chief MOH, to walk all of us through some of the highlights of this week's report and the key takeaways for public health.
Thanks, Dr. Strang. As Dr. Strang mentioned, public health's approach to managing the pandemic has changed, and so have our needs when it comes to surveillance and monitoring. But we are still continuously monitoring the data. During the acute response phase of the pandemic, our surveillance and epi efforts was focused on setting up systems and processes to collect data, basically almost starting from scratch. We had to quickly understand the virus and its impacts in Nova Scotia based on the data that were available to us while we were building those systems and that capacity. And the goal for a lot of that time was to identify and isolate every single case of COVID-19 in the province. That was when we thought we could eliminate this virus. For most of the last 2 years, Nova Scotia and many other jurisdictions have been reporting data to the public every day as a way to help everyone better understand what was happening. During the transition phase of the pandemic, our goals are different. We are no longer trying to identify every case of COVID. We all know that there is a lot of virus out there, and we do not need daily numbers to tell us that. Now we are looking at severe outcomes like hospitalization and death. The weekly report that Dr. Strang mentioned allows us to better see trends over time. We are still interested in seeing the daily numbers, and you can see those too in the weekly report. But monitoring them on a weekly basis helps us see the trajectory of an outbreak without getting caught up in the day-to-day fluctuations that we know are going to happen. Also, our health system partners have the knowledge and the tools necessary to address the day-to-day issues, whether that's dealing with a case in long-term care, managing capacity at the lab, or clinical treatment in hospitals. They know the number of cases admitted to their institutions each day, and they use this information for planning and management. And public health provides support, guidance, and direction when needed. This shift from daily to weekly has happened or is happening everywhere in our province, as well as other provinces and other jurisdictions around the world, not just in Nova Scotia, because it is best practice in public health surveillance and monitoring outside of an acute response scenario. And as Dr. Strang mentioned, we've taken the added step of making a report publicly available. I want to walk you through a few of the highlights in today's report and what the data are telling us. We reported almost 7,000 positive PCR tests this week, which is a notable increase from last week. This is not unexpected. Omicron, including BA2, is a highly transmissible variant and has more opportunity to spread. We're reporting 67 hospitalizations in the past week, and that's a concern. But the number of hospitalizations as a proportion of all of the total positive tests is still quite low, more than 3 times lower than in the first wave. And that is largely due to the impact of vaccine. The figures and data also show that hospitalization and death vary by age. Older people are at much greater risk of severe disease than younger people. Unfortunately, we are reporting 8 deaths this week, which is of course devastating for the families' loved ones. Deaths have been trending down since earlier this year, and overall the case fatality rate, or proportion of people with COVID who die, is substantially lower, both in terms of the population as a whole and in long-term care compared to previous waves, again, because of the impact of vaccine. In terms of what Nova Scotians should take away from this report, there's still a lot of virus out there, which means that we all should take steps to protect ourselves from exposure and infection. We know how to do that. The report also shows that the risk of severe outcomes is much, much lower when you are vaccinated with as many doses as recommended for your age group. The risk of hospitalization with Omicron is 84% lower for people with 3 doses of vaccine compared to people who are either unvaccinated or not fully vaccinated. The risk of dying is even further reduced. It's 92% lower with 3 doses of vaccine compared to populations who are either unvaccinated or not fully vaccinated. This is why we continue to stress why vaccine is important and additional doses are important. The other thing the data show us is that age and health status are the biggest risk factors for severe outcomes. And they also happen to be outside of our control, which is where the actions of the rest of us come in. We can use the things that are in our control, like getting vaccinated, wearing masks, staying home while we're sick, as a way to protect those at highest risk. Dr. Strang.
Thank you, Dr. Deeks. Surveillance is just one of the things that changes as we move from the acute response phase to the transition phase of pandemic management. This has been an unprecedented situation, and it required, over the last 2 years, an unprecedented response. Restrictions and mandates played a very important role, especially before we had vaccines and while we were still trying to understand a new virus. But public health restrictions were never meant to be in place forever. They can't be in place forever. As I've said before, restrictive measures have societal consequences too. They impact mental health, people's jobs and the economy, and their social connections. And those harms tend to have a disproportionate impact on marginalized and disadvantaged populations. And we cannot ignore these. Not only that, we know that also that restrictive measures become less effective over time. We do need to control COVID, but we also need to consider the very real consequences of the measures we use to control it. It's all about balance. You've heard me use that word many times before. And the balance between the two, controlling COVID and limiting harms, has fundamentally shifted. We are at a point now where we can no longer justify the use of restrictive measures and mandates. My chief MOH colleagues across the country agree that widespread restrictions are no longer necessary in the management of this pandemic. And I want to be perfectly clear on this point. At this time, public health is not recommending the use of restrictive public health measures. I'm confident that we are in the position to manage this pandemic without restrictions, even with the virus activity we are seeing in our communities. And here's why. We have a high level of immunity, mostly from immunization and also from infection. As we heard from Dr. Deeks, severe disease. We know much more about how this virus is transmitted and who is at most at risk for severe outcomes, which means we can focus our efforts where they have the most impact. And we have clinical expertise in the province and tools, treatment, and supports in place to help those at increased risk of severe disease and to decrease their chance of being hospitalized. That's why it's very important for Nova Scotians who test positive to use the online report support tool to report your positive test. For those who qualify, using that tool will connect you with our virtual care teams and a range of supports you can use at home to monitor your health and link you to early treatment options as well. Sorry, just turning a page. And we've been dealing with COVID now for more than 2 years. And I'm confident that Nova Scotians know not only what to do to keep themselves and others safe, but why these actions are important. After 2 years of a very directive, acute response, it is time to shift the control of COVID back towards individuals and families. But with that shift comes the responsibility to continue to think and act to keep others safe along with yourself. And you will not be left alone in this. Public health still has a lot of work to do, and for a long while. Managing public health in the transition phase of this pandemic involves a combination of surveillance, testing, vaccination, public health follow-up in high-risk settings, linking to clinical supports, and keeping Nova Scotians informed. That's how we've managed a wide range of diseases for decades. The job of the Chief MOH is to consider and prioritize the public's health. It's a job that I take very seriously and one that I am privileged to be able to hold. This government has always involved giving guidance and advice. This job has always involved giving guidance and advice to government decision makers and system partners. And I want to assure everyone that those lines of communication remain open. I also want to assure Nova Scotians that my commitment to prioritizing and protecting the health of all Nova Scotians has not wavered. Since the start of this pandemic, I've put my trust in Nova Scotians, and I ask you to continue to trust myself and public health. We are in another COVID wave, and there is a lot of virus around us, but we have the knowledge and tools to get through this, and I know we can. Thank you.
We'll now take questions from media participating by Zoom. We'll do one question and one follow-up in the time we have available, starting with Blair Rhodes from CBC. Go ahead, Blair.
Hi, Dr. Strang. I have a question for you. We've been hearing that hospitals are over 99% capacity and that surgeries are once again being canceled. What's it going to take to look at reinstating a mask mandate for healthcare facilities?
So we continue to look at the epidemiology of what's happening. We work with our health system partners. And we've talked about, that we will continue to bring forward appropriate recommendations to government for them to make policy decisions. At this time, we don't, as I've outlined, we don't believe we need restrictive measures or mandates.
Blair, do you have a follow-up?
Yes. Are you getting buy-in from the public? Because there's a lot of chatter in social media and elsewhere. People seem to be more nervous, and that the message that they're getting from you and your colleagues doesn't seem to be reassuring, that after 2 years of being afraid of this virus, they're not prepared to accept the advice that you're now giving, that, you know, we can relax some of these restrictions as long as we're careful. Are you finding that as well, that you're not getting the buy-in you'd like?
I think this is a difficult transition. There's always going to be some people who feel that we're going too fast and want to hang on to measures we've used for the past few years. There's also a lot of people who feel we hung on to them for too long. To follow the evidence, put forward evidence-based recommendations, and use all the tools with my communication colleagues to be able to reach out to Nova Scotians. I think there are a lot of Nova Scotians who understand where we're at. I'm also certainly aware that, you know, social media doesn't necessarily reflect the views of the majority of the population as well.
We'll go to Keith Doucette with Canadian Press. Go ahead, Keith. Keith? Keith, are you there? We'll circle back to Keith. Moving along, we'll go to Jesse Thomas with CTV. Jesse?
Hi, good afternoon. Thank you for this. And I guess my question, focuses around just the positivity rate that we're seeing. I spoke with an infectious disease expert saying it's somewhere between 20 and 30%. And given that level of virus in the community, they're recommending that masks should at least remain in public, perhaps as a rule, until the end of the respiratory season, in part because maybe it has to be a rule because behavior scientists say without it, we might not adapt. So would you recommend that people wear masking in public places? And why not make it a rule? Because it seems that's what the behavioral scientists are saying. We won't do it unless told.
So I hear lots of stories about many settings where the majority of people are wearing masks. Certainly, the public health recommendation continues to be strongly recommending that in places where people were required to wear masks, which is indoor public places and workplaces where you're around other people, especially where you can't keep distance, we strongly recommend that people continue to wear those masks. That is the public. Along with a range of other measures. The policy decision around that is up to others to do.
Jesse, go ahead with your follow-up.
Fair enough. I wanted to ask you about another concern. I'm just wondering how lockstep public health and the Houston government are working now on the transition phase of this COVID-19 pandemic. We're seeing you and the premier appear in a video talking about, the presence of COVID. It's all around us. Yet there's advertising coming from the government saying, let's get back out there. Really conflicting messages in a way. And I'm wondering if that shouldn't come with a bit of a warning. Should we be encouraging people just to get back out there?
So we continue to work with colleagues in government, talk regularly with the Premier's office, providing our public health recommendations and advice, and through our communication channels, providing public health recommendations directly to Nova Scotians.
Moving along, we'll go to Alexa McLean with Global. Go ahead, Alexa.
Thank you, Heather. Just following on Jesse's cue there, Dr. Strang, some members of the public feel that messaging is insensitive and contradictory right now to hear the province say, get out there when we see record number cases and hospitalization rates. Do you agree with public criticism that messaging right now contradicts the reality of epidemiology?
So I think the reality is that we're still the public health advice, and my advice is is for people can be out and about, make your choices wisely, follow precautions carefully. We have to learn that to COVID is part of our environment and will be here for a long time. And so, how do we actually and focus not just on COVID, but a range of respiratory viruses that we have to continue to be respectful about, follow precautions, but at the same time, people that we need to live our lives not like we did in 2019, but certainly more broadly than we have, but hopefully with a due respect for respiratory viruses.
Thank you, Heather. I'll go with my second here. Dr. Strang, recent stats from NS Health say more than 630 employees isolating right now due to some level of COVID around them. What is your take on the workforce pressures the current state of epidemiology is placing on the front lines of our healthcare, and how is that being mitigated?
So my job is to work in the area of public health with focus on looking at issues for all of Nova Scotians from a preventive perspective. I work closely with colleagues in the healthcare system who provide healthcare and run the healthcare system, but really they're the ones that need to respond to your question on how they're managing with workforce pressures.
Let's circle back to Keith Doucette, Canadian Press. Keith, you ready? Sounds like Keith is having some issues. We'll move along to John McPhee with the Herald. Go ahead, John.
Thank you. Can you hear me okay?
Sure can.
Great. Okay. Dr. Strang, you talk about the negative impacts of COVID-19 restrictions, and those are obvious when it comes to things like gathering limits and social isolation. But when it comes to the possibility of reinstating an indoor mask mandate, especially given the big spike in cases we've been seeing, what's the downside there?
So there is no downside for people continuing to wear masks. And that is the very strong public health recommendation that people continue to wear masks, especially in the indoor places when they're close around other people and they can't distance.
Oh, hello?
Go ahead with your follow-up, John.
Okay, yeah, just wanted to, this again for Dr. Strang. What was the rationale to offer a second booster to people 70 and older, as opposed to the priority population of people over 80 years old that was recommended by NACI? I'm just wondering what the rationale was behind those decisions.
Yeah, I'm gonna ask Dr. Deeks to answer that question.
Sure thing. NACI recommended that the population 80 years of age and older, as well as those in long-term care, should receive a second booster dose, and those 70 years of age and older may also receive a dose. So what we've decided to do in Nova Scotia is to recommend a booster dose for all of those populations, so 70 years of age and above. In terms of the rationale, although we know that the vaccine effectiveness against severe disease is maintained quite well with our booster doses, there is some evidence that the elderly have increased waning protection. So this second booster dose will boost their immunity and provide additional protection against severe disease.
Moving along, we'll go to Paul Bacon with All Nova Scotia. Go ahead, Paul.
Good afternoon. Can you hear me okay?
Yep.
Great. Dr. Strang, I understood the bedrock justification for public health measures was to keep the health system from being overwhelmed. And right now we know almost every hospital bed is full and surgeries are being canceled. Frontline workers say they need a break. What is the criteria that public health uses to decide whether or not our healthcare system is overwhelmed?
So public health does not have those criteria. We work closely with our colleagues who run hospitals as well as long-term care facilities. And we will listen to them, and they're the ones who identify when they need additional supports through public health measures. They have not identified that at this time. We were, as I said, we work closer to them, but ultimately that's their responsibility about to manage their system and put up their hand when they feel they need additional support.
And you mentioned just a minute ago that public health measures are less effective over time. Could you just explain why that is?
Over time, that people will become less compliant. So you need to use them in a focused and targeted way, but they are not long-term measures. Again, both because of the harms they can create, but also their effectiveness does wane. As I just said, it's simply because they only work when people would buy into them and use them and use them well. That by nature, human nature does wane over time.
Thank you.
Can I just add, it's not the measures themselves that are less effective. It's the, case isolation remains as effective now as it would have a year ago. It is really, as Dr. Strang said, the continued use of those and that people are not as compliant with those measures.
Moving along, we'll go to Stephanie Blanchette with Radio Canada. Go ahead, Stephanie. Stephanie Blanchette. Can you hear me, Stephanie? Okay, we'll circle back to Stephanie. Moving along to Tim Bousquet with the Examiner. Go ahead, Tim.
Hi, good afternoon, Dr. Strang. I wonder if you could kind of flesh out a bit the difference between rates and absolute numbers. The weekly report says that the rate of deaths is like 20 times lower than it was in the first wave, but we're having far more than 20 times as many cases, so the number of deaths is more. There were 6,000 cases last week. If the rate is 0.3%, can we expect 21 of those people to die?
So a lot of that depends on, we've got additional steps in place in terms of our reported support, early therapeutics, and virtual care. So ultimately, the outcome of somebody who's diagnosed positive depends on how well they are connected to those, additional supports. So, but I think what we have to understand is that that the rate applies to what is your individual risk, and we know that most of the vaccines that any individual's risk of getting severe disease is very low. There are factors, age and medical condition, which increase that for some people. But when you have the absolute numbers are driven by the absolute number of cases. But we're in this challenging period where the vast majority of people, and there's going to be lots of them that there have been, who get COVID are not going to get severe illness. So we have to, balance that is one of the key reasons why we have to balance the strength of our restrictions to control COVID, because the vast majority of people are not going to get significant harm from COVID. So we can't do more harms on the other side with our restrictions.
Maybe I'll just add that in the Epi report, you'll see death presented in a number of ways. So we are looking at it in multiple ways because each number tells us something a little bit different. So we'll have the absolute number and then the case fatality rate, so the proportion of deaths compared to the total number of cases. We need to look at them both numbers because we know that the total burden of COVID cases in this latest wave is so much higher. So even though the absolute number of deaths in this wave is high, when we look at the proportion of deaths compared to the total number of cases, it is almost 10 times lower than it was in the first wave. And then of course the death rates, which we look at in age groups, have the denominator of the total population. So we're looking, and that's because so we can look at the rates by age. And of course, the population size varies by age. So you can't just look at the numbers by age. We look at it in all those three ways so that we can see the complete story, if you will, of the epi in this pandemic.
Follow up, Tim?
Yes, I do. Some other provinces have made their COVID modeling public. I don't know if Nova Scotia even has that, but can you tell us what kind of death count we should be expecting?
So we model the Nova Scotia Health Authority as there's our leads on modeling, and they model really case numbers and hospitalization numbers. As I said, you could make some predictions around death, but a lot of that involves also factors around clinical care as well, which are hard to model.
Moving along, we'll go to Adam Cook with Talil. Go ahead, Adam.
Thank you very much, Dr. Strang, and thank you for making yourself available today. We really appreciate it. Dr. Strang, in February at one of the media briefings for Nova Scotia, you had used the figure, and please correct me if I'm wrong, that hospital beds in Nova Scotia were at 106% capacity as a result of hospitalizations due to COVID-19. Is there any similar figure that you can give us today based on the numbers that have been released this afternoon?
I don't request that from Nova Scotia Health Authority and IWK.
And go ahead with your follow-up, Adam.
Yes, thank you. You had mentioned mental health during the most recent briefing with yourself and Premier Houston as a key reason that restrictions were being lifted on March 21st. And I just want to bring that up because the last time I had a chance to ask a question to you, I had asked you about what you would say to those who are autoimmune, immunocompromised, immunosuppressed. I'll ask you the same question now, especially since the Let's Get Out There campaign really seems to almost be pushing people to go outside and get involved, even though we know there are large amounts of COVID-19 still around the province. What do you say to the immunocompromised and the immunosuppressed, framing it in that regard?
No, this is a challenging time, and ultimately, people need to be aware of their own specific risk factors for COVID, which are really the key risk factor is age and also underlying health conditions, and then work with people around them to decrease those risks. But that is no different than unfortunately, there are people, always have been people in our communities who are at increased risk for whatever reason, usually age and underlying health conditions from a range of infectious diseases. And to me, the most important point is that all Nova Scotians understand this, and that we all do what we could do, starting with getting vaccinated, masking when we're around other people. There are basic steps that all of us can take to protect those who are at increased risk. So we shouldn't leave those who are at increased risk on their own. And that is public health can't make you do that. To me, it's an obligation to all of us in the caring communities and society that we take on that, especially now in the situation where we are with COVID. Public health will tell you what you can do, support with information, but then ultimately, whether there's a mandate or not, ultimately it comes down to whether people are willing to take that action that shows that they care about others around.
And next we'll go to Victoria Walton with The Coast. Go ahead, Victoria.
Thanks. First off, I'm wondering about the arrival, or if it's already arrived, of the Paxlovid COVID antigen treatment in Nova Scotia. Are we using that on people who have severe cases of COVID or who are at more risk? And how frequently is that being used?
So I think there's a couple of things there. There's oral medications, early treatment, such as Paxlovid, which we have been using for a number of weeks now. And that is exactly why we keep saying that if you're positive, whether it's a rapid test or PCR, go online and fill in report and support, because that then gets the information that identifies you if you are eligible and will benefit from that early treatment, like Paxlovid. There are also now, they're not yet available, but Health Canada is in the process of assessing the antigen type therapies, which are really meant for prophylactic treatment for people who are at very high risk, such as immune suppressed. So we are waiting for Health Canada's assessment of those, and then we'll roll those out in between public health and our clinical partners as appropriate to make them accessible to those who are eligible. But again, they have not yet been approved by Health Canada.
Go ahead with your follow-up, Victoria.
Thanks. And my second question kind of is multi-part, but it's all with regards to rapid test reporting. And we are still, like you just said, recommending that people report when they test positive on a rapid test. What are those numbers like? Do we think that we're hearing about, and I mean public health, do you think public health is hearing about, half of the positive rapid tests, 75%? Like what do we think? And I guess second to that, are those being confirmed with PCRs? Basically, how many are we missing completely from the numbers that are being reported in the weekly COVID update? And why can we not include these rapid test numbers that public health knows about in the report?
So we're not collecting the rapid test results for surveillance purposes, but the purpose of that is to link people through to those therapeutic initiatives. We have lots and lots of PCR, and more than enough PCR for surveillance. The purpose of surveillance is to identify where we are on the wave and the epidemic curve, and we have more than enough information to do that. Basically, what we certainly do, people who have a rapid test do have the option to then confirm that with a PCR. And every day it varies a bit, but it's roughly in the range of about 50% of our PCRs that we report are people who have already had a rapid test. And that's one of the reasons I'll come back to a previous question where people asked about the positivity rate. Our positivity rate is greatly skewed simply because a significant proportion of the people doing a PCR from which the positivity rate is obtained, they're testing their PCR because they've already been identified as having COVID. So I think we have to, those of people who are looking at the positivity rate need to understand it is a very skewed number at this point in time.
Okay, we have one final question from Keith Doucette. He's having difficulty with his mic, so I'm going to read this for him, Dr. Strang. I'm wondering if it's known whether the B2 variant is helping to drive the increase in positive lab cases, and is there any way of quantifying it?
So we firmly believe that it is. So our process is that through the lab, working with public health, there are types of specimens that we then take and we ask to do strain identification on. So we batch those and then send them periodically to the national lab. It takes a bit of time to get the answer back because the national lab is doing this for across the country. And so far we did identify 3 cases of BA2 strain that were in January, February. What we're seeing now in terms of the rapid increase in cases and knowing that we already had BA2 around, I think it's a pretty safe conclusion that at least a good portion of our cases now are the BA2. So it's all Omicron, whether it's BA1, which is what we had January, February, or it's the cousin of Omicron now, BA2, both of which are highly infectious and can spread very rapidly, which is what we're seeing.
And that's all the time we have for questions today. Thank you for joining us for today's update.